Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, MARKUS HOMe welcomes Professor Emilie Cornec-Le Gall in Brest, France, Professor Roman Müller in Cologne, Germany, and Professor Jan Halbritter in Berlin, Germany, in order to discuss the consensus statement on chronic kidney disease of unexplained cause, CKDx, which has been published in NDT a few weeks ago by the Genes and Kidney Working Group of the European Renal Association, with tonight's experts as leading authors, and which NDT's editor-in-chief, Professor Joachim Anders, Professor Andreas Kronbichler, and I picked as our paper of the month for a detailed NDT MARKUS HOMe webinar. Dear Emilie, dear Roman, welcome back at home after our recent webinar on NDPKD. Dear Jan, a pleasure to host you for the first time. Dr. Emilie Cornec-Le Gall is Professor of Nephrology in the Department of Nephrology at the University of Brest in France. Dr. Roman-Ulrich Müller is nephrologist at the Uniklinik Köln in Cologne, Germany, and Professor of Translational Nephrology at the University of Cologne. And Dr. Jan Halbritter is Professor of Nephrology at the Charité in Berlin, Germany, and head of the Center for Rare Kidney Disease. In addition, he is the recipient of this year's Scientific Honorary Award, or Wissenschaftlicher Ehrenpreis, of the German Society of Nephrology. So congratulations on that.
Thank you very much, Gunnar, for this nice introduction, and hello, everybody. On behalf of my colleagues here, Jan Halbritter and Roman Müller, and on behalf of all the board members of Genes and Kidney, it's our pleasure to present today our consensus statement on chronic kidney disease of unexplained cause, not referred to as CKDx. Here are our disclosures. And we know that you are all very familiar with this figure, the KDIGO classification for chronic kidney disease, so the CGA system. And while G for GFR and A for albuminuria are used widely and daily by everybody, the C for cause is often neglected. And I would like to present a clinical vignette to introduce this consensus statement. It's a story of a 73-year-old woman who reached kidney failure. She had a long-standing history of hypertension. She had small kidneys with small cysts, and she was diagnosed as having hypertensive nephropathy. She was highly sensitized, and her daughter, 42 years old, with a perfect kidney function, offered to donate. So she had a CT scan showing only a couple of millimeter-sized cysts. And during the nephrectomy, small but visible and multiple cysts were seen on the kidney. And this led to a post-donation whole genome sequencing analysis, leading to the identification of a pathogenic variant in a gene named DNAGB11, and to the diagnosis of DNAGB11 kidney disease, which is also known as ADPKD DNAGB11 or ADTKD DNAGB11, depending on the clinical presentation, which is a monogenic kidney disease with autosomal dominance and with, in the clinical course, published median age at kidney failure of 75 years. Now, if the diagnosis of hypertensive nephropathy hasn't been made, if diagnosis uncertainty had been acknowledged, she could have been considered as having CKDx. Maybe this would have triggered a pre-donation diagnosis workup and a low cascade screening, and would have informed selection of donor. So we know that monogenic chronic kidney disease or kidney failure are quite prevalent in the pediatric population. This is also the case in adult cohorts, and we can say that it's approximately 20% of our patients. The diagnosis yields of genetic study differ among studies because it really depends on the inclusion criteria. But overall, monogenic kidney disease are quite frequent amongst our patients, and there are multiple references. If we look at the registry data about kidney failure of unexplained cause or unknown here, so in green here, you have 19%, but this is without considering the 14% here of hypertension, which in itself is not a diagnosis leading to kidney failure. So CKDx or kidney failure here of unexplained cause is quite prevalent. And CKDx accounts approximately for 20% of incident kidney failure cases. So as we said, and this is without taking into account hypertensive nephropathy or other diagnosis of convenience. Currently, there is no consensus on a common definition. Diagnosis of convenience lead to systematic underestimation of true CKDx prevalence, and there is no guidance on diagnosis and reporting. And this was the starting point of our discussion within the board, and that's how we decided to write a consensus statement on the topic. And this quote that is often quoted by my colleague Halbritter here when he gives a talk on CKDx, and that was added in the manuscript, illustrates very much this concept. The greatest enemy of knowledge is not ignorance, it's the illusion of knowledge. And we really believe that acknowledging diagnosis incertitude, or that no diagnosis is better than a wrong diagnosis. So what's the definition? So our first statement is that the cause component of the KDIGO-CGA classification deserves specific attention, considering its impact on patient counseling, prognosis, and therapeutic strategies. 2, CKDx is a diagnosis of exclusion, and we suggest classifying the cause of CKD as CKDx in all cases in which a specific cause cannot be defined in a given healthcare system after reasonable diagnosis workup. And of course, it will depend on the countries, and it's important to take into account potential limitations in access to or availability of modern diagnostic technologies. We wanted to emphasize the fact that naming causes with low diagnostic certainty or unspecific terms, including histological injury patterns such as FSGS, for example, may lead to unnecessary, potentially harmful or missed therapies, and is likely to discourage further diagnosis workup, even as additional diagnosis approaches become available. So if the diagnostic process do not identify a clear cause, the condition should be classified as CKDx. It's really to avoid the diagnosis bias of premature closure. And we believe that nephrology should evolve to a cause-directed approach in all cases of CKDx. So the second part of our consensus statement aimed at describing the diagnosis workup. And really here, the idea is to start from scratch and reanalyze all the components of the medical history of the patient and of the familial history. And so this means adopting an investigational mindset, a bit like a detective, and going back to the source preferably. So the family story deserves really quite some time, but can be highly informative. We'll come back on this just after. But also coming back to all the initial reports, trying to obtain if kidney biopsy was performed. It could be a good thing to review the kidney biopsy and review what specific staining were performed, etc. Review the imaging, review what immunology assays were performed. And so revisiting and taking a specific dedicated time in revisiting the diagnosis. And so such a systematic approach helps to secure the full use of diagnosis opportunity. And so our practice point really aims to underline the importance of familial history. So we recently published a short review on the topic, which is 10 tips on how to take a proper family history in CKD patient care. In short, we insist on the fact that the visit has to be prepared. It's better if the patient knows what they will be discussing. It needs dedicated time. This cannot be rushed, but it will save a lot of time when the history is well collected. It's important to ask the questions individually rather than is everyone well in the family. It's important to recognize variable expressivity of the disease. It's important to explore the consanguinity here. The parents of our proband are second-degree cousins, for example. So pedigree, it's important to draw pedigree, and we give advice on this. Derive inheritance pattern, facilitate screening in relatives, and update periodically, because taking a familial history is a dynamic process. The extrarenal manifestation can be very helpful in the diagnosis ascertainment. These are examples of patients from my clinic here with amylogenesis imperfecta here in the patients with Claudin 19 tubulopathy, or here an OFDR1 patient who has also distinctive features. And you cannot probably read in detail this sunburst plot, but it is accessible in the manuscript. And we tried to list, it's not exhaustive probably, but there are many examples of extrarenal features that can be associated and that can orient the diagnosis to a specific cause. So now reporting of CKDx. And so what we chose here is really to anchor this nomenclature on the CKD KDIGO classification. So CGA, and what we want to emphasize is that if the cause is not identified, then CKDx should be used. And then we suggest also recording whether a kidney biopsy was performed, whether genetic analysis were performed, and if it's the case, it would be H plus G plus with a date. And if it's not the case, this would be a CKDx H minus G minus. And of course, there will be iteration process, and a patient is, of course, and that's the aim, might not remain in the CKDx box, or but maybe after larger investigation will remain in the CKDx box, but this time with H plus G plus. And that's why the date is very important. It's really to underline that the case has to remain open for investigations. So what about genetic testing in patients with CKDx? Genetic testing should be considered in all cases of CKDx. We say considered, and the expected diagnostic rate of genetic testing depends on the presence of several factors in the patient history. Of course, in individuals under 60 years of age, it is increasingly regarded as a standard diagnostic approach. Omission of testing in this population should be supported by a clear clinical rationale. The genetic testing modality and genetic infrastructure may vary between healthcare. The minimum required selection of genes to test CKDx is a comprehensive kidney disease gene panel, considering of genes with moderate to definitive evidence for gene disease association, for example, and we list several resources such as ClinGene, PandaLab, etc. It's important to emphasize the fact that an inclusive or negative genetic test does not exclude the genetic cause. And last, identification of a pathogenic or likely pathogenic variant does not necessarily indicate that the variant is causal for the patient's kidney disease. So it's really important to, in the interpretation, to take into account the full clinical phenotype and the inheritance pattern. And to conclude, so CKDx remains a major challenge in nephrology, and it highlights the need for a structured, cause-oriented approach. And we really think it goes beyond genetics, and I think that's something we will probably discuss just after. Moving away from imprecise labels, for example, primary FSGS, hypertensive nephropathy, toward the CKDx frameworks, allows for diagnostic clarity and periodic reassessment. And all this is a necessary step toward precision nephrology, and last, broad adoption by clinicians, societies, and coding systems will be essential for this classification to be implemented in practice. So before moving to the discussion, I would like to acknowledge all the members of our board here, so the Genes and Kidney Working Group, and so and our new board members also. So do not hesitate to reach out. Thank you.
Well, thank you very much, Emilie. That was great, and I would just to start to kick off with one pressing question. So how do you foresee going forward and implement that on an European or global scale?
Thank you. So that's why this discussion with you is so important. What we believe is that there are several steps to be taken. One would be to harmonize the diagnosis reporting, the registry, probably the diagnosis codes also, because the fact is that there is no box or not clear box, not any clear box for diagnosis uncertainty. And this forces nephrologists to choose a diagnosis of convenience. So this would be a first important step, and I will invite also my colleagues Jan and Roman to comment on this point.
Should I start, Jan? Maybe you know, the thing for us, this was really a story that was very important to us because we felt so much of a need to change the situation there. I mean, there's much of a need to develop nephrology towards precision medicine. There's many things to be done, but we felt the first step is probably not, I don't know, highly tailored precision medicine for one disease, but defining what's the correct diagnosis, and this should be pathophysiology based. And if this concept is adopted, we'd already be happy. I mean, it's not necessarily said that the field adopts the term CKDx. We felt we need a term because it's all about terminology and giving things a diagnosis and something people understand and can classify in the end. We thought a lot about this term, and it's actually Emilie's suggestion in the end, because there's a lot of uncertainty in the field, and that's why we would fully back up this term in the future as well and try to get people to adopt it as well. But in essence, if the concept is adopted, somebody has a better term, and this is the global term for it in the end, I think all of us would be fine. But we have to start somewhere. Some of the uncertainty, right, comes out of the idea that we're talking about CKDU as unknown etiology. We're talking about unexplained cause. And these are using broad terms for something that may be more specific entities and so on is always difficult. But we also felt the dispute of what this should be called, what CKDU is exactly, could not be part of our definition now, and that's why it needed a new term and something that is not taken by other disease entities yet. And CKDx is also something simple that people can remember, right? Instead of coming up with something very complex. So we feel it's a good term. We also feel it's a term that can lead to adoption, and we are convinced, and that's why we kept the concept rather simple, that adoption is really key now. And it's not about finding the perfect classification yet. There is no perfect classification, but getting the concept adopted. And we feel this simple nature is a good basis to do so within Europe. And there's many thoughts we have about this, and probably Jan wants to share some thoughts on this as well, where you either from a society level can do it top down or the other way around and start with actual practicing nephrologists everywhere to come towards national consensus on how we want to deal with this. I don't know, Jan, how you feel about this.
Yeah, I think I couldn't agree more. I mean, I think it needs all the levels, the national, the European, the international level. And of course, it's an open discussion. However, as Emilie nicely showed, this is somehow integrated, or the concept we came up with was somehow integrated in the CGA classification, and we felt that the CGA classification is a very well adopted terminology everyone is using, but the cause component is kind of falling behind the G&A terminology, and that's why I think it is also a very, let's say it would be in an ideal world, it would be really nice if we could at the end also convince KDIGO to take the discussion into their hands and to open the discussion on a broader KDIGO level, and maybe open the CGA classification to a concept that integrates CKDx, whether it has to be termed CKDx or something else, but just to take this concept of having an unexplained etiology as part of the CGA classification would be great, I think.
I think the concept is fully convincing, but I think it will be a challenge to implement it into clinical practice, because honestly speaking, we do not use the CKD, EGFR, albuminuria categories consistently in all our doctors' letters and files. And I still see many people, even in nephrology departments, in whom the diagnosis still runs something like chronic kidney insufficiency without any mentioning of G or A categories. So I think it's a good way to go.
May I add, I like CKDx very much as a term, and I like it that KDIGO at least tries to force us to use the CGA algorithm. And as Gunnar said, I mean, we don't even use the KDIGO heat map in most hospitals. But nevertheless, the cause is very important. And if you believe Rajiv Agarwal, and I'm a little bit a semantic guy, he even doesn't believe that there is a hypertensive nephropathy, and this is the most coded nephropathy. And so it's a very good step in the direction forward. But maybe I can give you some feedback. We had last Saturday a national meeting. Andreas knows it, our rain day. And we had CKDx, the paper, as a talk. And the audience were largely practicing nephrologists. And at least it was my feeling, there was this, okay, so what do we do now? So regarding the translation to the practice, and I saw from the discussion that I tried to initiate was, first, the first pacemaker is the genetic testing. What should be tested and how long does it take? And do you have maybe data on that when you have a suspicion on CKDx? How long does it take to get at least the inclusion of the diagnosis? Is it like in vasculitis or so, 6 months, about 6 to 12 months? And that we have some kind of thresholds where we can look forward, maybe we get it in 1 or 2 months. And yes, I like it very much what you did with this extrarenal manifestation map. So my question is this a patent? Because as also Andreas knows, we like to use it in our app in Austria. It's widely used. And I can imagine that before it was always a kind of testing of how well educated are you as a nephrologist with all the extrarenal manifestations of some diseases. And I could imagine that this is a really good map that can be used on an app or in diverse offices in the regular setting.
Thank you. So for the sunburst, there is no patent, and all the credits goes to Nikola Zagorek, who is a nephrologist in Croatia, in Zagreb, and is doing a lot of nephrogenetics, and he spent 1 year in Brest, and they had a ERA long-term fellowship last year already, so I will be happy to know that. And I agree, printing this as a poster in the resident office, I think is quite nice, actually. And as for the the timeline for genetic testing, it really depends on the different countries. Technically, it is fast. The interpretation takes more time, and it really depends how many people, both trained in genetics and in nephrologies, are available, or how many duets are available to return the test in a timely manner. I would say, for example, in France, you can obtain some exome or large panel in less than 2 months. Whole genome would be 4 to 6 months, but it also depends on, and some panel will be long, but it really depends on the expert available. And then it's always also, it really depends if a pathogenic variant really clear is identified, it will be short turnaround time. But if there is, if there are several variants of uncertain significance, and then they would maybe need some more digging or functional assays and so on, it can be a longer story. And it depends on the country. Maybe you want to comment on the situation in Germany, for example.
I think it depends pretty much on who's your nephrologist and where you are and where you live and how the reimbursement system works. This is in Germany, even within Germany, quite fragmented, to be honest, and it totally depends on where you are and whom you talk to. And even within our university, between university hospitals, it's different because some of us have the right to send out the diagnostics and others don't. So this is a problem. But I think, and if you ask me for CKDx, how long is the turnaround time? We wouldn't be able to tell because until now, most CKDx patients are misclassified. And you indicated that with the hypertensive nephropathy, right? So we really have to change this as a very first thing. My view on this is even if a center says genetic testing would be useful and this center cannot directly do it, the turnaround time is probably a year or more until people have their diagnosis, at least the diagnostic exam performed, and many patients get lost. So that is a challenge that's very important. But this is exactly where CKDx also plays a role, because we don't make the point anymore that somebody says, okay, I don't know what the patient has, it'll take forever with the genetics, I don't know how to do it, so it gets completely lost, and we use a diagnosis of convenience. But we use a diagnosis now that will tell everybody it's CKDx, H minus, G minus, that there's things missing, right? Somebody has to fill in. And every time you read the diagnosis, you notice this is really missing and somebody thought about it might make sense. And I think that's very important so that it doesn't get lost in the diagnostic workup. There's much work to do for harmonization across Europe globally, not talking about global levels there at all. But on the other hand, such a classification can be the basis to this discussion in a way and can also force nephrologists outside the centers for the German situation, for example, to then get back to us and say, okay, I have this CKDx case now. It says G minus. Should we turn the G minus into G plus? And how can I do this? And this is still missing, this interaction. It will get very interactive and will need this interaction between nephrologists and centers that have expertise in genetics as well.
So I think there must be some kind of reference centers, at least for Austria, because we have also this fragmented situation with genetic testing. Because when you have dialysis centers with at least 100, 150 patients, you have CKDx there. But the practicing nephrologist there is lost. And therefore, even in larger centers, I always get the results of VUS, so variations with unclear significance. They do not know what they do, and then the document is then ending somewhere. So I don't want to be too fashionable, but do you imagine that maybe AI could play a role in this regard? So you have, of course, you would like to have a detailed family history, but the typical situation is, yes, my father was on dialysis. I'm here now also on dialysis, so that's it. Nobody else is there. Parents are divorced and so on. But with some kind of algorithm like AI, maybe you could then help the practicing nephrologist in a smaller center. Not everybody is working at a large university hospital. Maybe much more.
If I may just add something to this, who can actually maybe also drive or kind of gear the situation is, I think, the transplant centers and the centers that are recruiting for the transplant waitlist. They have a huge responsibility, because for a while we did these systematic genetic analyses in the transplant waitlists, and whenever we went, really in the beginning, we went manually through all the electronic health records, and we could see that almost half of the patients didn't have a kidney biopsy before going into kidney failure. And this is, of course, due to because as we all know, CKD is often asymptomatic and people are just diagnosed too late. And then it's, of course, at dialysis, it's too late to obtain this kidney biopsy, and then it's genetics that can maybe help in such a situation. But it actually needs both. Probably we need to, even at that point of kidney failure and planning transplantation, it's not too late to consider CKDx as an indication for genetic testing, because there's implications for the transplant management and so on. And I think the transplant centers could actually help in implementing that for that group of patients.
Did you also embrace the diseases that are genetic but that are not structurally related to the kidney? So, for example, I think of a young lady who has obviously an autoimmune tubulitis. Her father has it, her grandfather has it. So are such patients also included?
Yeah, of course, we know in PKD there's no histology, but for the remainder of patients where we usually in our field rely on kidney histology, oftentimes it's just missing because it wasn't done before going into kidney failure for multiple risks.
Okay.
And in essence, just to say that again, right, we have a certain focus that was also put there into the statement on genetic workup, because that's something that classically still has a major gap in implementation right now. But the term CKDx takes into account histology, takes in account anything you need. There is also in the workup we propose there, right? There is there's obviously descriptions of autoimmune results you need, etc. PP, PLA2R antibodies, ANCA, etc. That's quite clear. And this also is, on the one hand, a crucial piece in saying something is CKDx at all, because something that has a positive ANCA is often not CKDx probably, so to turn it the other way around. But there are many diseases at the moment still that may have a genetic component, or it may be polygenic or whatever, but that are surely not necessarily simple monogenic diseases in our CKDx. And this should be a part of that. In essence, we can't decide. As long as it's CKDx, we don't even know where the journey is going. Monogenic disease is an important part of it because the diagnostic yield is also significant among these patients, but it will include everything. And I think it has to include everything, because at this very important step, and that's the key concept of the statement at which we admit it's CKDx, we don't know. We have to be proud that we noticed we don't know, right? It's entirely unclear what it is, and there it shouldn't exclude anything at all. And will AI play a role? Definitely. Does AI play too much of a role yet? Not yet, but this will be rapidly changing. But there's still things we have to solve on many levels, from data protection to technical questions and harmonization and interpretation of results. But it will have to play a role, because this world is getting very complex. On the other hand, we wanted to start with a very simple thing of just admitting we don't know, right? And then the question of how do I enrich for somebody who has a high diagnostic yield for genetics and so on is partly in this statement still eminence-based, because this is the point at which you talk to a center potentially as well if you don't know. But as long as people in the field would make this point, I don't know, I call it CKDx, I think we'd already be very happy for a first step, also taking into account, Gunnar, what you said before, CGA, much of it is often not reported yet. So we'd already be very, very happy about this first step.
In a perfect world in Western Europe, say France, Austria, Germany, how many of our patients should undergo in 2025 genetic testing? So not selected patients who are awaiting allografts, but just ordinary clinical CKD patients. What would be your gut feeling on that?
I would say that in our field, when you talk about CKD differential diagnosis, right, you first think of kidney histology. That's still in adult nephrology, it's still kind of the gold standard. So if kidney histology is inconclusive, then of course it's always genetics, which has to be, in my view, and I think in our view, can speak for all of us, has to be done next. And then there is situations where you shouldn't do histology prior to genetic testing, because the pre-test probability for having a monogenic kidney disease is so high. Maybe the family history is just very, very indicating. And then it's not justified to do an invasive diagnostic procedure when you can do genetic testing first. But I think it's really, that's why we also put the H and the G in the middle of this classification, because we think it's either histology or genetic testing or both that it takes for principal differential diagnosis in every CKD patient.
And may I add the question, do you completely refute the diagnosis hypertensive nephropathies? So a patient, say 70 years of age, who had 30, 40 years of hypertension, never really well controlled, say 160, 150 or something, maybe even primary hyperaldosteronism. Would you still call this CKDx in the future?
I think that most of the hypertensive nephropathy do not have long-standing uncontrolled hypertension. When I review the cases, they were initially non-controlled, and then they went controlled. So I would say that a very large majority of the cases, it's not a good term. And even if, for example, we think about the cause of monogenic hypertension, there are some rare diseases causing monogenic hypertension. They do not progress to CKD. So I don't think that hypertension alone is a cause for CKD. Of course, if the patient had malignant hypertension with TMA, and that's a different story, although there is probably an underlying cause of this malignant hypertension, but I would tend to refute it in more than 90% of the case. I don't know what's the opinion of, well, I think
I fully agree that the point is, now saying this doesn't exist is probably going to the other extreme, but has a political goal, right? And this is an important goal. And what I definitely would want to reach is, while hypertensive nephropathy, and I usually try to find better terms for the individual patients, and some have vascular reasons and so on. So we might have better terms there. And I totally dislike the term benign nephrosclerosis, which is often used in this context as well, right? So there we can be very clear. But what definitely has to be the goal is that we turn this common diagnosis into the zebra. And the zebra is probably much more common than we expect if we consider that people think that genetic kidney disease is a zebra. And it is a large proportion of our patients. And if we think about patients with significant CKD, so let's say stages G3 down to kidney failure, and we do not think about the population 85 years old in intensive care, which is a different question and often is an acute setting as well, then I do think, yes, we're surely talking about 30% that needs genetic testing at some point. And this will get more and more most likely because we're going to learn more. And kidney disease is not simple. It's multifactorial often as well, right? I mean, and that's what we know by APOL1 as well in a way. So it will be a complex of causes. We know that with common genetic diseases as well, one PKD patient shows much faster kidney function loss than another. And that's obviously true that other factors like hypertension, obesity, diet, etc. play a major role. So it's never that simple. But the genetic part of the cause is much more common than we believe. And I think we got to think about this in probably 1 in 3 patients.
And just to add this, what about diabetic nephropathy? So are we still allowed to use that term? Same, again, pattern, 30 years of diabetes mellitus, not really well controlled. Would you accept this as a diagnosis, or should this also by default be CKDx?
No, I think what we see very often is diabetic nephropathy just assumed without histology proven findings, and that is something that is problematic, we think. So, but bona fide diabetic nephropathy in a kidney biopsy, and often it's, diabetic, hypertensive mix kind of imaging. But I think that's of course a valuable diagnosis. But the problem is rather that we often assume diabetic nephropathy without even having done kidney biopsy.
But we also have patients for like type 1 diabetes that underwent biopsy. We also did this a year ago. They do not have at all diabetic nephropathy, but have CKD stage 5. So I would consider them CKDx. And coming back to Guda's example, I mean, if you have primary aldo, you have a clear cause for the kidney failure. It's not hypertension, it's aldosteronism. But let's say a 35-year-old hypertensive young man who has CKD stage 4, we had 4 such examples in 1 year, I would consider them CKDx. And therefore, it's a milestone if you do CKDx because it's a step forward towards precision medicine. Because why does this guy have, at the end of the day, then kidney failure if it's not, TMA and such kind of.
And even if it turns out that the hypertension damaged the kidney, right? The question is still, why did that person have? There has to be some very peculiar reason for that. And CKDx can even help to find the extrarenal cause if there is.
What I use in my report is CKDx with long-standing and controlled hypertension, or CKDx with type 2 diabetes, if I'm not certain that it is a diabetic nephropathy. I think that we can use it in the other. And speaking about what's the percentage of patients who should undergo genetic testing, I think we also have to take into account the resources, because we do not have currently enough molecular biologists to test 30% of our clinic, 30% of the patients. But I agree with the number given by Roman. But the reality is that we also have to make sure that we will still be in the capacity of increasing the access to genetic testing, and that's a very important topic in my view.
And again, I guess CKDx can help there, right? I mean, if we have a well-characterized population, and this population is called CKDx, and 90% of them is missing a genetic exam, that clearly, shows that we have a lack of access as well. And I think that's an important point, and we still do. And part of this lack of access is lack of resources, but parts of it is also lack of infrastructure in the sense of people just don't know. And that's something we definitely need to change, and that's a common effort. And again, I mean, classifying the patients to see where these patients are and where there is the lack of diagnostics also allows benchmarking, right? I mean, a center can have 500 CKDx patients and 90% have a genetic exam, and another one, but that is something we have to find out. And that also helped for international harmonization, because we'll learn much better and be able to quantify how that works in the Netherlands, where it's surely different from Germany and Austria and Turkey. And that'll help to also in the context of policy making. And all of this motivates people to consider going the full way of diagnostics. And we'll need that to, in the end, be able to classify our patients, develop new therapeutics, really come up with the right trials, and have our patients and cohorts trial ready as well.
It will be interesting what KDIGO will say to this term, CKDx, but I'm looking forward to that. But I think you force them to be humble, because you have at the end a Socratic approach, which means as a nephrologist, I know that I know nothing somehow. So maybe really 90% are really CKDx patients, maybe, yeah.
And I think one of the relevant things you should not forget is that if you give a patient a label of CKDx, maybe also the access or reimbursement of genetic testing will be easier for you as an individual, because that's sometimes, of course, limiting the approach to genetic testing. So I think this is really, really helpful. And I really need to applaud you for this initiative and how far you have been taking that, and also the resonance you got on social media, of course, and in real life.
You get more access to expensive therapies, maybe, with the Krankenkasse.
That's also good. That's also good, of course.
But there we really need the field's help, right? I mean, we for us, this is really important, and we felt it's important. And the longer we think about it, talk about it, discuss about it, the more we think it's important. I mean, and in the end, for us here, but also for everybody listening, right? I mean, this is nothing that can be expert driven. There's either the field adopts this down the road and we do this together, or it will not fly, because it can't fly in an expert center based manner. It'll fly if the field goes this step.
One more clinical question. Does your classification also apply to transplant patients?
Sure.
Of course.
I think if there are no more questions, I think we can conclude and say we hope that you're taking this forward. KDIGO will implement it, and you will get a broad support also from the ASN for that initiative. But I'm pretty sure there will be movement in the field, and that's why we are here for. Nephrology is exciting as never before, and thank you for this good initiative, and keep the work for ERA up, and hope to see you soon in person. Thank you very much.
And the last word this time comes from Markus and me, Andreas, because we would sincerely like to congratulate you to your academic change, to your new position that you started on 1st of October as head of department in Innsbruck. We are very proud of you and our MARKUS @Home team, and we are aware that more academic changes may take place in the next year. So thank you.
Thank you very much.